Today I'll be presenting to you oral findings and dental treatment for a pediatric patient with Alagille syndrome. My name is Damon Cole, and I was supervised and aided in this case by Dr. Maj and Dr. Caesar, and we are located at Marquette University School of Dentistry in Milwaukee, Wisconsin. So for disclosures, I have no financial relationship to disclose concerning the content of this presentation. Alagille syndrome is a rare autosomal dominant condition that presents in 1 in 250,000 live births. This condition is a result of a genetic mutation in the JAG1 gene, which affects cell-to-cell communication in specific tissues, most often the heart and the liver. Liver issues arise stemming from the constriction of bile ducts, and this leads to cholestasis, or an accumulation of bile throughout the body. Cholestasis has been shown to negatively impact bone formation systemically, and this is apparent with oral manifestations such as hypomineralization, hypoplasia of teeth that are developing during the time of cholestasis. This case report details dental treatment for an 8-year-old patient with Alagille syndrome. For this case report, an 8-year-old male presented to the Marquette University School of Dentistry Pediatric Department. This patient was diagnosed with Alagille syndrome at birth, and he also has hereditary hemochromatosis and renovascular hypertension. He was short in stature and did not show proper physical maturation for a patient his age. Mom reported no cognitive delays and stated he did well in school. The chief oral complaint was pain on chewing, mainly on the right side, and there was also signs of swelling on the same right side. The oral exam revealed hypomineralized first permanent molars as well as maxillary and mandibular permanent incisors that were beginning to erupt. He had very poor oral hygiene, and this resulted in heavy plaque accumulation, and therefore generalized gingivitis was present. The child was in pain, again on the right side, so number 16 and number 46, and the glass ionomer was placed as a temporary material after caries excavation was completed. The dental needs were then addressed in quadrant dentistry, and the importance of improving oral hygiene was reiterated throughout. You can see the treatments that were rendered in the upper right chart, and you can see that at age 8 we have already placed stainless steel crowns on his permanent dentition due to severe breakdown of those permanent first molars. You can also see that we did catch some lesions early and we were able to place resins, but we will have to make sure we maintain them on a 3-month prophy schedule so we can make sure that no further breakdown occurs. So for dental management with young patients with Alagille syndrome, we need to make sure that we improve their oral hygiene and decrease further breakdown of their hypomineralized or hypoplastic teeth. This is very time sensitive, and we need to make sure we help monitor the condition after all dental treatments have been rendered. We recommended a 3-month recall follow-up, and we want to ensure that we keep a close eye on the permanent dentition as it erupts as well. We do not want new lesions to occur, and so this 3-month recall will help us prevent that. For a patient with Alagille syndrome, early diagnosis and proper management is very important, especially during their formative years of growth and development. We need to make sure they establish a dental home early and immediately determine the severity of their oral manifestations. We need to create a recall schedule that best aligns with the treatment needs of the child, and we need to continue to properly discuss OHI and show the importance of that. Throughout this process, we want to make sure we communicate often with their primary care provider, and in doing so, we need to understand that dental problems are often not the main focus for a child with Alagille syndrome. Thank you.